I'm going to talk about what progress we've made in the last 10 years, but this next slide, it's not that I can't count. I just want to make it clear to you that actually diagnostics have been moving forward for a lot longer than the last 10 years, and that we had the commercial assay, the ELISA, for galactomannan back in 1995, and for 10 years before that we had latex-based antigen tests. It's just that we didn't really know what to do with them. And so I think what I want to tell you is that we've actually been learning how to use these tests and understanding more about what they mean in the last 10 years, rather than making any massive, great, sweeping progress. But 10 years ago, we were in a position where we didn't really diagnose fungal infection at all. Most of it was only diagnosed after patients had died, and we had various criteria that we used to describe it, of suspected or proven. The definitions, consensus definitions that first came to us and were revised in 2008 and are about to be 2004 and about to be revised again, have really helped us understand what we mean with the different diagnostic criteria. But even then, 10 years ago, we were just using empiric therapy. It was the standard of care throughout Europe and the UK. And we weren't using it very well, because the end result was that about 70% of haematology patients would receive empirical antifungal therapy at some stage during their treatment, even if we knew that they were relatively low risk and that the risk of infection was 5% or less. We still would treat the vast majority of them with what was then potentially toxic and very expensive antifungal therapies. And other patient groups in the intensive care unit and transplant patients, again, where the risks we now know are relatively small, large numbers of them were receiving unnecessary and often prolonged antifungal therapy. In the past 10 years, though, we have seen more diagnostics become available to us. In addition to galactomannan, we've got beta-D-glucan, and we've got the lateral flow device, which you'll be hearing more about later. And we've seen a development in PCR. Now, PCR has been around for a while, but it's really in the last 10 years that we've seen a massive growth in the publications and in their application into diagnosing fungal infection in specific populations, particularly haematology. We've also seen the genomics and the proteomics and the metabolomics, and we're just beginning to realize what they can do for us as well. But we're not quite here yet, are we? This is really what we want to be in the next sort of 10 years. We want something that's going to give us a rapid result. And we're nearly there, but just not quite. So here's my first question, and I'd like you to tell me what you think is the most useful test for aspergillosis at this current time. Oh. Well, we're going to be having a debate on this later on this evening, but I just think that there's obviously, this shows me that we're still fairly low down on the learning curve. But it's gratifying to see that galactomannan is improving in its popularity and that PCR is there, but there's still 7% of you, 7% that think that there isn't, or that's something else. Would anybody like to say what that something else is? Oh, shush, shush, shush. Okay, can we move on? Thank you. Why did you choose your answer then? What was your decision for whatever answer you chose? There we are. So at least we're not governed by cost. That's quite good. But most sensitive, most specific. They're all sort of good answers. There's nothing wrong with any of them. And can we move on? But what I hope to show you is actually where we use rapid results, it's relatively little to do with their performance. It's more to understanding what their limitations are and what the results mean. And they mean different things in different situations and different populations. And it depends on your patient population, your prevalence of disease, and what you're trying to do with that result. And you need to know how you're going to use that result when you're managing patients. And often it's going to be a negative result that's going to be more useful for you if it's going to be able to rule out a diagnosis and mean that you don't have to use empiric therapy in situations that you used to. So the various ways we could use a diagnostic test, and this isn't just for fungal infection, this is for everything. You might be wanting to rule out a diagnosis to avoid empirical therapy in immunocompromised patients. You may be wanting to identify carriage of a potential pathogen, and we use that widely in MRSA screening, and we use it to inform infection control. You may not want a prognostic test that assesses the need for antibiotics, and we can use CRP and procalcitonin in that way. Or we may be monitoring response to therapy, and increasingly we're seeing that our diagnostics, galactomannan in particular, is useful in that respect. And finally, you may actually want a test that rules in your diagnosis and gives you a good test that gives you confidence that the patient has a specific disease. Now, they're all different things, and the different properties of a diagnostic test are going to be needed to give you what you want out of those options, and you may have different cutoffs and different positivity criteria in those different situations. So how have our current diagnostics performed? We've got the galactomannan here, the beta-D-glucan, and the PCR. They've all now got methodological recommendations and standardizations, 2 of them because they're commercial, and the final one, PCR, because we have actually now got standardized recommendations for various specimen types, serum, plasma, whole blood, and shortly bronchoalveolar lavage, that do allow the procedure to be standardized across centers, which has been a real problem with PCR prior to this. When it comes to quality control, then there is control material within the kits, and it's all there, but is it external quality control? Not always. And in fact, the only methodology where external quality control is available is for PCR. And I think that is an issue that we need to bear in mind from sort of clinical governance point of view and how we implement these tests across our patient populations. You can see the sensitivity there is quite variable, but for galactomannan and PCR is approaching respectability, whereas the specificity is high throughout. There are false positives with all these tests and false negatives. So have they been used in diagnostic strategies? Well, galactomannan and PCR have. Beta-D-glucan lags a bit behind, probably because we haven't actually got the cutoffs adequately worked out or knowing what it means in a situation. But where we are making progress, and I think this was alluded to earlier by Rebecca, is that we're realizing that combinations of diagnostic tests are becoming much more useful than a single test on our own. And I think we know for a long time that we have to use all of the diagnostic skills we have available to make a diagnosis of fungal infection in an immunocompromised patient. So using both antigen-based and molecular tests, we can look to use less empirical therapy, diagnose fungal infection earlier, use less antifungals, which will save costs, and hopefully, and there is some evidence emerging for this, have less proven disease, which should translate into decreased mortality, decreased hospital stay, and further cost savings. So this was a paper from a couple of years ago now from the Australian group, where they used a randomized controlled trial to really compare their standard of care with empiric therapy with a PCR and galactomannan-driven based arm, and clearly showed that the biomarker-driven group received far less antifungals and less empirical therapy. And that was really one of the first hallmark randomized controlled trials that showed that this strategy worked. Not only that, it was safe. There were no adverse outcomes associated with using the biomarkers to determine therapy. This, however, is a very recent paper, and it's really exciting. It's from the Spanish group, from Manuel's group in Madrid. And again, they've randomized their groups. But here, they're acting on their galactomannan and PCR results to actually drive the further diagnosis and drive the initiation of antifungal therapy. And when compared to the standard of care, they've shown that actually not only do you reduce antifungal therapy and empirical therapy, but they have reduced mortality as well, and they have decreased proven and probable fungal infection. And I think that's a really good outcome. And this is, I think, probably one of the best studies I've seen in recent times. And here's just a significant effect on mortality in the biomarker-driven group. And that's using combinations where they had galactomannan in both arms, but when they put the combination together, this is the added benefit they got. So, evidence that we should be using combination PCR and galactomannan. We've had similar studies, not randomized controlled trials, so this is cohort studies, but we've had using the combination of galactomannan and PCR in our haematology patients in Cardiff since 2005, so for the last 10 years. And again, in the sort of retrospective analysis that we performed on them, we have shown that the performance of these diagnostic markers when used in combination is good. The negative predictive value is really, really high in combination, so you can confidently exclude fungal disease. But when you use them together, particularly when you've got multiple results, you are starting to see a really highly specific diagnosis of invasive aspergillosis. And when you use that to initiate or decide whether you're going to initiate antifungal, you can show a marked decrease in antifungal expenditure that far outweighs the cost of implementing these diagnostics. So here we've got our antifungal expenditure. Turn it around the right way. Doesn't show up on the screen. Oh, there we are. So antifungal expenditure coming down, and antifungal usage remaining the same. Those of you that know what we've done in Cardiff will know that this wasn't maintained, and when we took the eye off the ball, it went way up again, and we had to implement an antifungal stewardship program to bring it down again. But looking at the outcomes that you can achieve, all combinations have shown decreased empirical therapy, earlier diagnosis, often by more than a week, sometimes several weeks, and decreased overall antifungal usage. And although the Australian group actually showed an increase of probable proven disease because they were using the tests to initiate radiology, and they weren't actually treating until there was proven probable disease. The group that treated on the basis of the biomarkers and the combinations, the Spanish group, have shown a decreased disease. And although we didn't initially in our cohort studies look at the difference in incidence of disease, since we implemented our stewardship program, where we actually use what word you like, it might be policing, it might be enforcement, but we actually guide the preemptive strategy, and we stop the antifungals when they're unnecessary. We have seen our antifungal incidence come down quite markedly from around 9-10%, where it has been for the last few years, to currently around 3 to 5%. Now that might be sporadic, it might be something else, but it's something we're looking into, but we think it could be because we are now treating patients before overt disease develops based on a biomarker diagnosis, because we have confidence in it. So they never reach the proven probable criteria because they don't get radiological signs that are consistent with it. So, next question. So what are PCR and galactomannan best used to do? Do you want to exclude the diagnosis? Do you want to rule it in? Do you want to determine whether you need to do a high-resolution CT? Do you want to use it to decide who you're going to put on antifungal drugs or you're not? Or do you want to do a complicated combination of any of the above options? Would you like to vote now? Quite an even spread, but most of you want to do all things. And I think they can do all things, but they won't do all things in all patients. You have to decide which patient group, could we move on? You want to use this in. And this is some different diagnostic strategies that you might want to use. So if you've got a really high-risk population who have got an incidence of disease of sort of 10% or more, you may decide you want to screen them using these markers twice a week. And if they get positive, if you get both positives, you may well at that stage decide you're going to implement antifungals if you've got a high suspicion, or you may go down further diagnostic routes of CTs and lavages and even tissue diagnosis. You may, if the incidence of aspergillosis in your patients is not that high, you may decide you're just going to maybe screen them when they've got fever or where they've got clinical signs. But again, you might decide on the basis of the biomarkers you're going to treat them at that stage, or you might go down a more further diagnostic pathway. If your incidence is very low, then probably you're still in the realms of using empiric therapy during refractory fever, but there should be a time-limited maneuver that buys you time to implement the diagnostics and decide whether or not that antifungal therapy is warranted or not. So here, I'm doing a bit of seeing how much you absorb. So this is a definition of preemptive therapy. What do you think best describes the term I've used? It's used quite widely, and it's used sometimes interchangeably with diagnostic-driven or targeted. What do you think the definition of preemptive therapy is, and which of these best describes it? Is it based on just risk factors? Is it asymptomatic patients who are positive biomarkers, or is it the radiology? non-specific, or is it something else? Can you vote on this now, please? Maybe I'm not getting through. But actually, I would say 2 and 5 could both, in various ways, be interpreted as being preemptive therapy. Although technically this is something sort of we've thought up, that if you've got your biomarker positivity and you've got absolutely no signs of infection, use of an antifungal then might be considered targeted prophylaxis. That's maybe a bit of semantics. If you've just got your signs but no biomarkers, that's empiric therapy that we're used to. Whereas if you've got biomarker positives and you've got clinical signs, this is what I consider preemptive therapy. Once you wait for the clinical signs to develop that you see radiologically, then you have missed the opportunity for treating infection before disease has developed, because you've already got clinically overt disease that you can see on the X-ray there. So that is not preemptive therapy. And I'm taking this from our way that we understand it in terms of treating CMV disease. So that's targeted therapy. And of course, once you've made the diagnosis, you've completely missed the opportunity. So we've got outcomes from our biomarkers that we really have established. We can make a more accurate diagnosis, we can make it earlier, we can decrease morbidity and mortality, and all of the associated knock-on effects that that could have. In the wider community, though, so we need antimicrobial stewardship that targets our antifungal use to actually make sure that people act on the results in an appropriate way. And we also need to be looking at resistance, antifungal resistance in a more focused way now. And we've got other tools that are going to help us. We've got the genomic era now that we can identify specific host factors. We can look at the pathogen-related factors. We can put them together and integrate them with the bioinformatics that are being developed very rapidly in a matter of minutes and get far more information than we had before. And we could be using these technologies to feed into what we know about our molecular diagnostics and our antigen tests and get much more value from them than we currently are. So we'll be hearing more about host responses, but we know that the host response to fungus, the innate response, is really quite highly attuned to recognizing fungus quickly, but there's a number of different responses we can see, and the one we want to get over infection is really a protective response with pro-inflammatory response, but immunocompromised patients often can't mount it, and they often end up with chronic disease, and they also can get a lot of immunopathology driven through these responses here, which are protective but also harmful, and sometimes you'll get sort of chronic infection that they can't eradicate. So understanding where the host is and how they're responding to a particular fungus infection is important. It's also going to be driven by the host immune status, the immunocompromise, and also by what the antigen-presenting cells are and how they're functioning, and various other things, including the fungus itself, will be largely driving the response, and it can take over and take advantage of immunocompromised patients to potentiate its own survival and allow and prevent eradication. Also, we're now realizing that genetic predisposition is playing a really important role, and there's a number of different susceptibilities and genes that are involved in our immune response, and there's polymorphisms that we see in these genes that are really quite frequent, and this can be a single nucleotide change that's occurred, a SNP, and these will occur in the population in instances up to 50% in some cases, and more than 28 have been linked to a susceptibility to fungal infection, and prime amongst these are probably the C-type lectin receptors, and these are a whole family that will recognize fungus and really sort of keyed into recognizing fungus and bringing about a protective immune response to it. And the number of different SNPs have been looked at in this population, and we, in our group, and this is just some preliminary data, but in over nearly 400 patients, we had genomic DNA. We genotyped them against 4 recognized SNPs that were said to possibly increase fungal infection, particularly invasive pulmonary aspergillosis. There wasn't a great deal known about most of the functions of these genes or how they were doing it, but we put them together, very simple assay, very cheap, and we just looked at them. And the results when we got them through, they weren't terribly encouraging, but 3 of the SNPs that we looked at did have increased odds ratio for invasive fungal disease. We looked at Candida as well, but again, nothing to write home about. But then what we found really interesting was you could see patients, stem cell transplant patients, who changed their genomic profile from what was potentially a low risk to a high risk, depending on their donor, or the reverse, a high risk profile to a low risk profile. And there were 41 patients out of those 400 who actually changed during, as a result of their stem cell transplantation and a donor. And 22 changed from low risk to a high risk mutation, and 19 changed from a high risk to a low risk genotype. And what was just interesting there, and these numbers are too small to really sort of do anything with, but this is just fascinating, isn't it? The incidence of invasive fungal disease, if you go from low risk to high risk or high risk to low risk, is really quite substantially different. So it opens up the possibility that we can actually put some selection into our donors, if we've got the opportunity to choose one that could potentially protect them from invasive aspergillosis and other diseases. And the high throughput genomic sequencing that's going on means that we can put in masses of data on masses of genes in a very short period of time and actually select the patients that are going to be at highest risk and try and do something to protect them. So this is opening the path of tailored therapy, where we use not only the biological markers of infection to rapidly diagnose potential pathogens, but also we can look for resistance markers. We've got commercial assays that can look for azole resistance on your PCR result for your aspergillus. You can look at the host pathogen interactions and pick up patients that maybe are more at risk of developing disease. And you can look at their genomics and see the populations that are really predisposed to developing infection, and also their likelihood of responding to treatment. And so I think that's where the next 10 years is going to take us. And I think that's the future, and hopefully we're going to be able to looking at that. And Peter will recognise this, because this is something that we've put together where you're going to try and combine the genetics, the biomarkers, and the host response information in a rapid fashion within sort of the first few days of a patient coming into hospital receiving therapy or a transplant. Put it into that little black box that is going to crunch all that data in ways that I can't possibly understand, and come up with your specific risk for a specific infection and specific disease. And in this case, the risk of aspergillosis, and you may decide if it's low, you'll just monitor them, but if it's high, you might want to put them on antifungals at that point. And that really is personalised medicine using our diagnostics, and we are going to be getting there. It is not something pie in the sky. This is something that is real and is coming, and we should embrace it. So accurate and early diagnosis will select the best therapy for the individual patient, and I think we've moved a bit from here to here. Thank you very much.